All right, good morning, everyone. Thank you so much for coming. I'm just going to start and really what I wanted to do is thank John Laughlin, who's here today. Really in this time of uncertainty and chaos related to our federal funding and research getting cut, I think the generosity of John and his family is so incredibly important to our institution as a whole and to the Division of Cardiology. For those who don't know, his family has endowed multiple professorships in our division, as well as our Bruce Laughlin Fellow, which Shauna is going to be presenting today and has been given this past year. And this award is frequently, no pressure here, a stepping stone to faculty at our or other institutions. About 50% of the prior awardees, I was looking through this, we actually have a few here today, Fareed, Kenta, have become faculty here. For those also who don't know, John's stepfather was Robert Bruce, our first division head of cardiology. And with all of this uncertainty nationally, our faculty who've received funding from John know that they're going to be able to continue their groundbreaking research without worrying if that research is going to be cut at any moment. So really, John, thank you from the Division of Cardiology. You've been a friend to us for over 20 years, and we're really grateful for that. And now I'm going to pass this off to Kelly.
Thank you. I'd like to echo thanks also for all the support over the years. It's now my pleasure to introduce someone I'm sure that everyone in this room knows and many of us know well. So Shauna Newton comes to us not quite whammy, but pretty close to whammy. Who started off college, went to Montana State in Billings. Went to the University of North Dakota School of Medicine just because Montana wasn't cold enough. And then decided to take a little trip to the East Coast to a small little, slightly unknown university and went to the Massachusetts General Hospital, of which she completed her residency in internal medicine. And then we were so fortunate to have her come to the University of Washington here, where she has certainly shown that she is a true star and just a wonderful colleague, and is now finishing out her year as a chief fellow, which is probably the best part of fellowship, is completing the year of being a chief fellow and no longer having to worry about schedules. But I had a chance to meet Shauna, obviously early on. Always knew she was a superstar. She's done such great work here, and had the opportunity to talk to her about her interests. And of course, she is going to be transitioning now into the cath lab and will become one of our interventional fellows. And we are very proud to have her here. Shauna and I have been working on the spontaneous coronary artery disease, the International Spontaneous Coronary Artery Disease Registry together, for which Shauna was able to secure funding from the Alpha Phi Foundation to fund this. And we're going to talk a little bit about this later on, some of our work, which has been rather onerous to get started, but we continue on. And it is my pleasure to have Shauna present to us today, Not Your Daddy's STEMI, a modern look at SCAD. Shauna. Sorry, I interrupted. My apologies. Because we do have to give Shauna, she is also the Bruce Laughlin awardee, as introduced. So I'd like to present this nice little lovely piece of paper here that can go into your office, hopefully here at the University of Washington in a couple of years. No pressure. But this is the Division of Cardiology Bruce Laughlin Fellowship to Shauna Newton for outstanding academic contributions and potential, Shauna. And then you can hang that up later. But in the meantime, Not Your Daddy's STEMI. Thank you.
Thank you so much, Kelly, for that thoughtful introduction, and thank you all for having me today. We're going to take a modern look at spontaneous coronary artery dissection, also known as SCAD. I have no disclosures. And so I wanted to start out with a couple patient cases. And we have Miss Pink and Miss Orange. Miss Pink is a 51-year-old woman. She has no known past medical history, and she developed chest pain during her daily 5-mile jog. Miss Orange is a 37-year-old woman. She's 1 week postpartum from her 7th pregnancy and developed chest pain after picking up her newborn. Both of these patients presented to the emergency department for further evaluation. Upon arrival, both patients underwent an EKG, and both patients had a troponin, which was elevated. So we can see with Miss Pink's EKG, it's fairly unremarkable. She's in normal sinus rhythm. She has no STT changes. While Miss Orange's EKG tells us a different story. She had progressive ST elevation in her anterior leads with reciprocal changes in the inferior and anterior lateral leads. And so both of these patients undergo coronary angiography. Here again, we can see Miss Pink's coronary angiogram. We can see that there's a tubular stenosis of the second obtuse marginal branch with about 80 to 80% true lumen narrowing. Mrs. Orange's coronary angiogram is much different. We can see multiple radiolucent lumens and dye hang-up involving the left anterior descending, left circumflex, and likely the distal left main. There's also TIMI-1 flow to the distal LAD, and you can see the heart function is poor even on angiography. Unfortunately, Miss Orange ended up progressing to cardiogenic shock. And so as we move through this presentation, I just want you all to think about how you would manage these patients. Would you have taken to the cath lab for coronary angiography? Who should undergo intervention? What medical therapies exist for SCAD? And how do we prevent future SCAD events? So that brings me to the outline of my talk. So today we will describe the evolution of spontaneous coronary artery dissection as a recognized clinical entity, recognize key diagnostic features of SCAD and the role of multimodality imaging, and outline current management strategies and emerging research directions. So just a little bit of history. Dr. Pretty wrote this case report in 1931, and this was the first case report of SCAD, so I'm just going to read this to you. Between 8 and 9 a.m. on November 12th, 1930, I was called to see a married woman who had been very ill all the previous night. The history was that soon after partaking of a good meal of fried fish and chip potatoes obtained from a neighboring fried fish and chip shop, in which the rest of her family had shared with her with no ill effect, she was suddenly seized with severe retching and vomiting, which persisted throughout the night. On examination, the pulse and temperature were normal. Nothing was found in the abdomen and nothing in the chest other than a soft systolic murmur at the apex. Having satisfied myself that I was not dealing with an abdominal catastrophe and the cause of the trouble was fried fish and chips, I prescribed 1 ounce of castor oil, a mixture of bismuth and soda, and 3 minims of dilute hydrocyanic acid for each dose. No food and rest in bed. This woman was age 42. Unfortunately, the next morning at 3 a.m., Dr. Pretty was called back to the residence because she was found deceased. She endorsed chest pain and worsening nausea and vomiting, and a post-mortem examination revealed a right coronary artery dissection and rupture with significant hemopericardium. So how has our understanding of SCAD evolved? In 1973, we had a case series of 6 women status post-autopsy describing hematomas in coronary arteries, specifically without atherosclerosis. And 2 out of these 6 patients were peripartum. They concluded that maybe this is hormonally related. In 1989, which is the figure shown here, this was a case series of 94 SCAD cases, of which 73% were found in women, and 31% of these occurred postpartum. They noted that women tended to have dissections involving the left coronary system, while men had more frequent dissections involving the right. And as we can see, women had much more severe disease. And so this leads us to our current SCAD definition. It's a non-atherosclerotic, non-traumatic separation of the layers of an epicardial coronary arterial wall. In the 80s, we discovered that we could diagnose SCAD and coronary angiography with evidence of dissection flaps, reinforcing the utility of angiography as the primary tool for SCAD. Fortunately, our coronary angiograms have improved since this time. And so pathophysiology, what do we know about SCAD in the current era? Well, unfortunately, it's not well characterized, but probably not due to bad fish and chips. There's two different theories for the development of SCAD. The first one is the outside-in hypothesis. This proposes that SCAD begins with bleeding from the vasa vasorum. These are the small blood vessels that supply the coronary artery wall. And that this bleeding leads to formation of an intramural hematoma. And after this, we can develop a dissection flap, but some patients do not have a dissection flap. Additionally, there's the inside-out hypothesis. This suggests that an intimal tear starts first, and then you have bleeding to the vessel wall, creating a false lumen, similar to what we see in aortic dissection. Most SCAD cases are diagnosed with advanced imaging or pathology, and a large majority of them actually don't show an intimal tear, so the outside-in hypothesis is favored as the preferred mechanism. We also know that SCAD patients have a higher density of coronary adventitial vasa vasorum in non-culprit segments compared to patients without SCAD. And so this was a study that used OCT to evaluate the adventitial vasa vasorum in patients with SCAD, 9 patients, and 18 sex-matched controls with non-obstructive coronary artery disease. And what they found was that SCAD patients demonstrated a significantly higher vasa vasorum volume despite having less plaque volume. And so in normal coronary arteries, we generally have few or no vasa vasorum unless they are diseased. And so in disease states, the vasa vasorum may proliferate abnormally and extend deeper into the media or near the intima. And so this study was just an interesting finding that even in non-corporate arteries of SCAD patients, we see just a higher volume of vasa vasorum, potentially underlying a mechanism, suggesting a diffuse arterial abnormality rather than a localized effect. SCAD predominantly affects women, accounting for 87 to 95% of cases, but it can affect men. So I just want you all to remember that. It's a mean age of 44 to 53 years, and among women under 50, SCAD is responsible for approximately 35% of acute coronary syndrome cases, and 5 to 17% of all SCAD cases are associated with pregnancy. SCAD most commonly presents with chest pain, 85 to 96% of patients, often with classic myocardial infarction associated symptoms that we think of: radiation to the arm, nausea or vomiting, radiation to the back, diaphoresis, dyspnea, all of the classic symptoms. It can lead to acute coronary syndrome in 90% of cases. 20 to 50% of those cases are going to present with STEMI, and it can be associated with severe complications, including ventricular arrhythmias and cardiogenic shock. So remember, just going back to our patient population, Miss Pink and Miss Orange, both of them presented with chest pain. They both presented with ACS, and Miss Orange presented with a STEMI. Additionally, Miss Orange progressed to cardiogenic shock. And so really our first step in management is, as we do with all patients presenting with chest pain, obtain a troponin and EKG. So I just wanted to take a pause and talk about pregnancy-associated SCAD. What do we know about it? SCAD during pregnancy, SCAD can occur during pregnancy or within the postpartum period, and it's typically within the first month postpartum, which we can see on this graph here. Postpartum SCAD or PSCAD, pregnancy-associated SCAD or PSCAD is defined on having a SCAD event during that pregnancy or usually within 12 weeks after delivery. Potential triggers for PSCAD include hormonal changes, vascular remodeling, and shear stress, but we really don't understand the mechanism well. And then, unfortunately, PSCAD is more likely to present with severe features. These patients more often have STEMI, they more often have heart failure with reduced ejection fraction, and they have higher rates of multivessel or proximal dissections. They also have a higher MACE rate, 50% in SCAD, driven by persistent LV dysfunction. And we can see that the mean age of these patients is younger than the average SCAD patient. So instead of 44 to 53, we have a mean age of about 34. It's also more associated with patients that are multiparous. Just suggests that maybe repeated exposure to pregnancy and the stressors with pregnancy can contribute to the increased susceptibility. And so, again, I just wanted to emphasize PSCAD, STEMI rates are higher, LVEF is going to be lower in these patients, and left main and multivessel dissections are going to be more common. And so our epidemiology, in general, we suspect that patients have a cardiocirculatory stress, which we can see outlined in pink here, are different examples of what we think those stressors are, acting on a weakened arterial wall structure that can be coming from multiple different things. So here we can see the most common precipitators are going to be emotional stress. This occurs in about 50% of patients. They'll endorse an emotional stressor as a precipitation of their SCAD event. Intense exercise is the second most common precipitator. This occurs in 28% of patients. This could be jogging, like our patient Miss Pink, or can be associated with straining and more using the Valsalva maneuver. Sex hormones and medications have been thought to be possible precipitators. There are some case reports and small case series that suggest that sex hormones may play a role, though this is not well understood. There are a lot of associated conditions with SCAD. Migraine is common. This is in about 40% of patients, and about 25% of patients also have associated hypertension. Just wanted to take a moment to focus on fibromuscular dysplasia and connective tissue disorders, as these can occur quite commonly in SCAD. So FMD, we can see that this presents in about 30 to 50% of cases. One case series suggested that actually was much more higher prevalent. They had 76% of their patients had FMD. Connective tissue disease can be associated with SCAD, though less commonly. It's in 2.5 to 5% of patients. There has been no monogenic basis for SCAD identified, though we presume that there's a lot of polygenic basis for SCAD. It appears to be influenced by non-genetic factors like hormones and vascular stress. And so fibromuscular dysplasia, just briefly on what it is. It is a non-atherosclerotic disorder of the arteries that typically presents in women. 90% of FMD cases are in women. It can manifest as arterial stenoses, which we see here, dissections, aneurysms, or tortuosity, and the classic finding on imaging is going to be the string of beads appearance. And because of how prevalent FMD is with SCAD patients, all patients should be screened for fibromuscular dysplasia, and patients should be screened for connective tissue disorders. We don't recommend blanket genetic testing for all patients with SCAD just because of the low prevalence, but we should be asking those questions, asking about personal family history of vascular events like aortic dissection, asking if there is any known genetic syndromes in their family, and then assessing for signs of joint hypermobility and distinct facial or skeletal features. We should also ask about frequent dislocations, easy bruising, fragile skin, scoliosis, history of pneumothorax. All of these can be associated with connective tissue diseases. And then FMD, it's most frequently found in renal arteries and in the cerebral vasculature. The main reason to do screening, we don't have specific treatments for FMD, but it's because 7 to 14% of patients can have cerebral aneurysms, and those can need specialized treatment. And so both Miss Pink and Miss Orange should undergo the one-time head to pelvis CTA imaging being preferred over MRI just because it has better resolution. So just to summarize, with SCAD patients, you should be thinking about a young patient with ACS and no traditional atherosclerotic risk factors. Pregnancy-associated SCAD typically occurs within 1 month postpartum, often presents with severe features. We talked about increased rates of STEMI, HFrEF, proximal dissections. Screening, all patients should be evaluated for FMD and connective tissue disorders with one-time head-to-pelvis CTA. So that leads us to our diagnosis. The gold standard for diagnosis is going to be coronary angiography. And we do have this YIP-SAW classification system where we've identified SCAD presenting as 4 different types. Type 1 is going to be kind of our pathognomonic SCAD features. So this is going to be the multiple lumens, the dye hang up. You can see evidence of that dissection flap in coronary imaging. Type 2 is going to be a long, diffuse, and smooth narrowing. This can be challenging as it can mimic other conditions, which we'll talk more about. Type 3 is a focal or tubular stenosis. Again, this diagnosis can be quite challenging because it can mimic things like atherosclerosis, and it often requires intravascular imaging to confirm. Type 4 SCAD is when you have complete vessel occlusion, and this is going to resemble thrombotic MI and angiogram. The most common type of SCAD is going to be our type 2. So remember, that's that long tubular stenosis. Type 1 is the second most common, and then followed by type 3. SCAD most frequently occurs in the distal LAD and obtuse marginal branch. I think what's notable about just this diagram is we can see that there's much higher rates of SCAD occurring in mid to distal vessels, whereas proximal LAD, proximal left circumflex, proximal RCA, and left main occur far less frequently. So you're going to be looking at the distal vessels when trying to diagnose SCAD. So I wanted to take a pause here and just have you look at a few angiograms, and let's see if you can identify which of these patients or all of these patients have SCAD. So I have 3 different patient cases for you. These are all patients that have been seen at UW, and I'm just going to let those play for a moment. I just want you to think about which one of these patients you think has SCAD. So it's actually only the second patient. The first one is an example of coronary vasospasm. This is of the ostial left main. The second patient had type 4 SCAD. They actually had a complete vessel occlusion of the proximal LAD that was only identified to be SCAD after intravascular imaging was used. And the third patient is an example of atherosclerotic CAD. SCAD is underdiagnosed, and it's because of this challenging, as you can see. And so the gold standard coronary angiogram, remember, it does not image arterial walls. It just looks at the lumen. The reason that making the diagnosis is so important is that it can mimic multiple other conditions. So the patient that I showed you with coronary vasospasm that we can see, their image on the left, unfortunately, they were not diagnosed with coronary vasospasm until after they underwent bypass surgery. So this patient ended up getting a lima to their LAD, which we now can see is very atretic. And here we can see on that angiogram that their left main is wide open. So no one wants to send a patient to bypass who is later diagnosed with coronary vasospasm on provocative testing. So what's an invasive workflow for suspected SCAD? The first thing that you're going to do is get a coronary angiogram, and you're going to look for all those SCAD features that we just talked about. If you have evidence of type 1 SCAD with a visible dissection flap or contrast staining, you pretty much have your diagnosis. That's going to be pathognomonic. One thing that you should consider is contrast streaming. This is an artifact that is caused by suboptimal contrast injection. As long as you don't have that, you've made your diagnosis of SCAD. For type 2 or type 3 SCAD, the diagnosis can be a little bit more challenging, and coronary vasospasm should be part of that differential. So in patients who have type 2 or type 3 SCAD, please administer intracoronary nitroglycerin. If the lesion resolves, you have a diagnosis of coronary vasospasm. If it doesn't resolve, consider intravascular imaging just to confirm your diagnosis. You can evaluate for features of SCAD. You can evaluate for SCAD mimickers such as atherosclerosis, and then you can get your diagnosis. For type 4 SCAD, this is our patient that I showed you before who had the complete occlusion. You should immediately go to intravascular imaging. This is going to be how you get your diagnosis. And so here we can see this patient underwent intravascular imaging. The IVUS is in the false lumen. All of this is that subintimal hematoma. And this here is the true lumen. So this is how we diagnosed our patient with type 4 SCAD. You also want to consider a differential for myocardial infarction with non-obstructive coronary arteries, or MINOCA. So just do a systematic approach to evaluate for SCAD. A lot of this is very similar to what I just described. Intracoronary vasodilators are going to help you rule out vasospasm, Intravascular imaging can be really helpful for identifying SCAD, atherosclerotic CAD, coronary thrombus, or emboli. And then consider coronary functional testing with provocative testing to evaluate for microvascular disease or provoke vasospasm. A left ventriculogram, which I feel like we don't use too often, but it can be used to help diagnose Takotsubo cardiomyopathy or an echocardiogram. Is non-invasive imaging helpful for diagnosis of SCAD? The answer is kind of. It can provide some adjunctive data. Echocardiography is going to be non-specific for SCAD, but 85% of SCAD patients have wall motion abnormalities, and about 26% of patients have HFrEF. Cardiac MRI can help support the diagnosis of SCAD, but again, is non-specific. So in patients presenting with SCAD, if you get a cardiac MRI, you'll just show features of myocardial infarction. You can also rule out MI mimics such as Takotsubo myocarditis or other cardiomyopathy. For confirmed SCAD, what you're going to see is evidence of late gadolinium enhancement. This can be transmural, subendocardial, or patchy. You might see evidence of microvascular obstruction. This is actually very common in patients with SCAD and can cause recurrent chest pain. You can evaluate for reduced LVEF and wall motion abnormalities. And you can see sometimes persistent features on delayed CMR. So what about CCTA? I think this is one of the most common questions and something that we are working on learning more about. We know that CCTA is great for chest pain. It's actually a class 1A recommendation to help us with diagnosing chest pain with a sensitivity of 96 to 100% and a specificity of 64 to 83%. But for SCAD, really the sensitivity and specificity is unknown. We have some characteristics that we've identified in CCTA imaging in SCAD patients, but most of these are non-specific. Tortuosity is common in these patients. 78% of patients with SCAD have tortuosity versus 14% with coronary artery disease. We have one study that really went to assess the sensitivity and specificity of CCTA for patients with SCAD. So this was on 32 patients who had coronary angiography confirmed SCAD diagnosis, and all these patients underwent CCTA imaging 2 to 5 days within their diagnosis. And so here we can see that the sensitivity is modest at best, about 60%. It's pretty good at identifying proximal SCAD, though we only have an N of 3. And then for those mid to distal lesions, it doesn't do as well, 59% sensitive. And so if CCTA is the only imaging modality used to rule out SCAD, you could be missing a lot of cases here. So in summary, invasive coronary angiography remains the gold standard. Non-invasive imaging provides adjunctive data for myocardial assessment and follow-up. And then remember just to use your other tools that we have in the cath lab. Intracoronary nitrates, intravascular imaging, or follow-up imaging can help clarify the diagnosis. Great. So you've diagnosed SCAD. What's next? So our approach to SCAD management, the first thing to do is determine if the patient is stable and do they have any high-risk features. High-risk features include left main dissection, ongoing or recurrent ischemia or chest pain, ventricular arrhythmias, or cardiogenic shock. If they are stable and have no high-risk features, then the preferred management strategy is going to be conservative therapy. And the reason is 95% of SCAD heals with conservative management. I just want to hammer that in. 95% can heal with conservative management. And so this was a study that looked at patients who underwent repeat angiography after their initial diagnosis that were conservatively managed. And they found that, again, 95% of those patients had improvement of stenosis severity from the index event, a residual stenosis of less than 50%, and they had normal flow in their coronary arteries. Okay, but what about Miss Orange? She's in cardiogenic shock. How do we help her? The first thing that you're going to want to do is provide her with additional support, and then she's going to need a revascularization strategy. At this time, there's limited data to support the use of to support like a preferred mechanical support device in SCAD. There's no consensus or recommended support device. In patients who need support, we do have to be careful. FMD can occur in the femoral arteries, and so those vessels can be really fragile when you're placing mechanical support devices. After that, our next step is going to be choosing a revascularization strategy, PCI versus CABG, and we'll discuss how you choose between those two. In our patient, she ended up undergoing PCI. Revascularization is not without risk just in general, but especially in SCAD patients. There's some unique challenges. It can be difficulty wiring the true lumen, especially in complex dissections, and so your wire can end up going into the false lumen. Iatrogenic dissection is common, and this can be just from your catheters or any of the equipment that we deliver into the blood vessels. Propagation of the hematoma can occur. This can lead to longer dissections, longer stents being placed, and fear of hematoma propagation and failure to use intravascular imaging can actually result in stent underexpansion and higher rates of in-stent restenosis in the future. And so we can see that a third of our patients who undergo PCI develop hematoma progression. Iatrogenic dissection is fairly common, 3% in patients just undergoing diagnostic coronary angiography, and that increases to 15 to 20% of patients who undergo PCI. Target vessel revascularization is also very common in approximately 4 to 26% of patients. And so here, this was just a study that was done by Mayo Clinic. They looked at 87 patients with angiographically confirmed SCAD. And this just compares outcomes between those treated with PCI versus conservative strategies. These patients, their therapy, PCI versus conservative therapy, was based on clinician discretion. So of course, there could be a lot of selection bias in this study. But we can see that while this wasn't statistically significant, there was higher rates of target vessel revascularization in the revascularization or PCI arm versus conservative management. What about bypass? Well, unfortunately, 50 to 68% of grafts become occluded on short-term follow-up imaging. One review of 24 grafts showed that arterial grafts actually fared worse. 7 out of 8 Lima grafts were occluded just on pretty short follow-up imaging of these patients, compared to 6 out of 15 vein grafts. And remember, that's just because SCAD lesions tend to heal. And so you're left with this graft that has competitive flow, leading to graft failure. Also, in some patients, bypass is unable to be performed because they have extensive distal dissections. You just have no landing zone for your graft. But the in-hospital mortality is pretty good, less than 2%. Are there certain PCI strategies that we have for patients who have spontaneous coronary artery dissection? The answer is yes. We do have expert consensus documents. This was actually a study that Dr. Carney and I submitted with Dr. Fairley, among others, about PCI strategies in patients with SCAD. The first thing that you're going to do is determine whether or not your guide wire is in the true lumen versus the false lumen. If your guide wire is in the true lumen, you have a few different strategies. One is cutting balloon angioplasty. What cutting balloons do is they just are used to decompress that intramural hematoma. A cuttering technique is a specific cutting balloon technique where you inflate and gently move the cutting balloon along the dissection flap. This just creates multiple fenestrations. And again, you're just releasing that hematoma, decompressing it. Really, your main goal here is going to be to restore blood flow while minimizing further vessel damage. In some patients, they do require stenting, and you want to make sure that stenting is only done if absolutely needed and flow is not restored by that cutting balloon or other balloon. And so you want to use long enough stents to cover both ends of the dissection. This is to help prevent further hematoma propagation. And size accurately using intravascular imaging. Remember, we talked about how a lot of these stents are undersized. Once that hematoma resorbs, you just have a small stent that's floating in a large vessel. And this can lead to increased risks of restenosis. For patients who have a guide wire in the false lumen, which we can see in both of these images, here is that subintimal space, which our IVUS catheter is in. This is the patient's true lumen. Again, here we can see that subintimal space. Here's the patient's true lumen. And so there are some specific strategies, which I won't get into a lot of detail in, but mainly these are techniques used to safely re-enter the true lumen. These methods often involve using a second wire, imaging guidance, or tools to relieve vessel compression and restore blood flow. These techniques are complex and they carry higher risk complications than standard PCI. So these patients should be managed in high volume centers with operators experienced in complex coronary interventions. What about medical management? We know this is just a prospective observational study. This is the best data that we have about medical management. This followed patients for a median of 3.1 years. And what they found is that hypertension is associated with an increased risk of SCAD recurrence. This is hypertension in the study was just defined as a physician documented diagnosis of hypertension or the use of antihypertension medications at baseline. They didn't give any details as to whether or not they were uncontrolled at the time of the study or not. What we also saw was that beta blocker therapy is associated with a decreased risk of recurrence. Again, this was an observational study. And we don't know the specific doses of the beta blockers that were used. About 50% of patients were on metoprolol. And so medical management, this is just based on expert consensus documents. We, again, don't have a lot of good data. Most of our studies are observational. And so this is the general consensus for medical management. Thrombolytics are considered to be contraindicated. They're associated with an increased risk of extending the dissection and worsening intramural hematoma. This has just been shown on case reports where patients have had these complications. And so because of that, anticoagulation is generally avoided as it may, again, just expand the intramural hematoma. And so anticoagulation is going to be part of our initial ACS strategies, and that's okay. But anticoagulation should be discontinued once we make the diagnosis of SCAD, unless there's another strong indication. Antiplatelet therapy, I would say most experts will recommend antiplatelet therapies, but the ideal strategy remains controversial. In general, all these patients are placed on a baby aspirin lifelong and then placed on Plavix, usually for 1 to 3 months after their SCAD event, longer if they've had a stent placed or an intervention. Beta blockers, as we discussed, are recommended based on that single observational study. ACE inhibitors, ARBs, and vasodilators are prescribed when other indications exist, and same with statins. And so medical management, what should be the medications that Miss Pink and Miss Orange get at discharge? Beta blockers, these are going to be recommended. The optimal dosing is unknown. They should undergo management of hypertension. This is just going to be with in line with our current guidelines. So global blood pressure of less than 130/80, though we don't know the optimal strategies. Antiplatelets, as I stated, they should all be on aspirin plus or minus Plavix for about 1 to 3 months. And then the main focus should be reducing potential precipitating triggers. Remember that emotional stress is a precipitator for 50% of patients. So ensuring if they have underlying comorbidities such as anxiety or depression, that these are being treated. A lot of these patients need therapy and need additional support after their SCAD event. Physical stress is also a common precipitator. And so in general, the consensus is to avoid Valsalva maneuver and have all of these patients participate in cardiac rehab. Future pregnancy, if you do have PSCAD, is generally avoided because of the severity of the SCAD presentation. And also, it's only a very small study of 32 patients who had PSCAD and underwent a future pregnancy. 3 of those patients had recurrent SCAD during their pregnancies. Hormone therapy is a big question and an unknown. At this time, most experts recommend discontinuation of any sort of hormone therapy or oral contraceptives just because of a potential link. Next, I'd just like to talk about 2 ongoing research projects. And just want to take a moment to thank the Laughlin family and the Alpha Phi Foundation for your grant support with SCAD research efforts. And so first we'll talk about the University of Washington SCAD registry. This is ran by myself, Dr. Kelly Branch, Dr. Kate Carney, and Dr. John Blair. Our inclusion criteria is going to be patients who are 18 years or older, have SCAD confirmed by catheter angiography or coronary CTA, and be able to provide consent and complete questionnaires. Patients with iatrogenic coronary dissection or atherosclerotic related dissection are excluded from the study. At this time, we have 37 patients who are enrolled, and this is just briefly some of our data. 90% of those patients are women. 2 cases have peripartum SCAD. About 27% have normal EKGs. 27% presented with STEMI. All patients had troponin elevation in our study, and 3 patients developed cardiogenic shock. Revascularization procedures have been performed in 27%, with 1/3 of those undergoing stent placement. 1 patient required CABG. This was at an outside hospital, and 1 patient underwent transplant. That was actually Miss Pink. Genetic testing has been performed in 14 of these patients and was positive in 2. 1 patient was found to have Loeys-Dietz, and 1 patient was found to have vascular Ehlers-Danlos. Fibromuscular dysplasia in our patient population has been found in 24%, and then DAPT and beta blockers are very common discharge medications. We're part of the International SCAD Registry, which has 29 active centers and over 2,000 patients enrolled. And so what Kelly and I have been working on for about the past year and a half is our iSCAD CCTA study. And so this is SCAD evaluation by CT coronary angiography. Our research aims to evaluate or refine the use of coronary CT angiography for diagnosing SCAD. Unfortunately, I don't have any data to show you from the study today, but I would like to just describe our current efforts. And so we're going to do this study through 4 aims. The first is going to be to establish a comprehensive database of CT and CCTA imaging from the iSCAD registry. The University of Washington serves as the core lab, and so we will be obtaining all of those imaging from outside institutions. We'll then assess the diagnostic accuracy of CCTA to detect SCAD. I'll go in a little more detail about these 2 aims. After that, we're going to develop, distribute, refine, and educate CCTA protocols to optimally evaluate SCAD, and then test CCTA against current standard of care. And so for our second aim, how are we going to do this? Well, we're going to include patients that have an adjudicated SCAD diagnosis by iSCAD reviewers with invasive coronary angiography. And all these patients will have CCTA and invasive coronary angiography performed within 2 weeks of another and within 1 month of SCAD diagnosis. And this is just because, again, SCAD heals, and so we don't want to miss those patients that have already undergone healing. To assess the diagnostic accuracy of SCAD, we will do this through 2 separate ways. One is going to be by level 2 cardiac CT reviewers who are blinded to the diagnosis. Our study will have over 10% of the studies will have no SCAD, and greater than 5% were reviewed twice to allow for intra and inter-observer variability. We'll be also using Clearly to evaluate the CCTA datasets for advanced automated luminal and extraluminal coronary analysis. And so we're just hoping to identify and validate the diagnostic features of SCAD: stenosis, plaque characteristics, coronary tortuosity, and fractional flow reserve. Our hypothesis is that total plaque volume and calcium volume in these patients will be low, and that high localized plaque volume will be with low total plaque volume, and that coronary stenosis and resting myocardial perfusion abnormalities will correlate. After this, we're going to track CCTA usage trends over time. We're going to reassess our diagnostic accuracy as CC technology and protocols improve. We're hoping to have a CCTA protocol where we can define best potential strategies, scanners, timing to diagnose SCAD. And then we'll prospectively evaluate CCTA features linked to SCAD outcomes and compare CCTA first versus standard care in a nested study. The last study that I just wanted to mention is being done in Europe right now, and I have been told that it is completed and that we should be getting the data hopefully later this year. The BA SCAD trials are going to evaluate DAPT and beta blockers. And so the goal of this study is to evaluate optimal antiplatelet strategies and beta blocker strategies in patients with angiographically confirmed SCAD. It's a prospective, randomized, open label, blinded study, so a probe design. It's also a factorial design, meaning that patients can be randomized into 2 different treatment comparisons, but not every patient will be in both treatment comparisons. So they have enrolled 600 patients, and first they're going to randomize them to either receiving 1 year of DAPT versus 1 year of single antiplatelet therapy, 1 month of single antiplatelet therapy. And then these patients will undergo a second randomization where they can either receive beta blocker versus no beta blocker. Excited for the results of this study, hopefully later this year. So that's all I had for today. I think I just wanted to summarize. These are the main things that I hope all of you can take away from this. So the patient population that you're looking for is a young patient with ACS, no traditional risk factors. And remember, it's more frequently in women than men, but can occur in women, or can occur in men, excuse me. All patients should undergo screening for connective tissue disorders and FMD. The FMD screen involves a one-time head to pelvis CTA imaging. The diagnosis, our gold standard, is going to be coronary angiography with or without intravascular imaging. Non-invasive imaging can be helpful for providing adjunctive data, but is not sensitive or specific for SCAD. For management, conservative therapy is going to be best in most patients. Medical therapy involves beta blockers, which are associated with a reduced risk of SCAD, hypertension management, and antiplatelet therapies. And then our active investigations are the iSCAD CCTA study and the BA SCAD trial. I have a lot of people that I have to acknowledge. Thank you so much for all of your help the last couple of years while I've been on this SCAD research journey. First, I just want to thank the Laughlin family again, the Alpha Phi Foundation, SCAD Alliance, and the CTU. All of these have provided funding for our research. Doctors Kelly Branch, Dr. Kate Carney, Dr. John Blair, they are all part of the University of Washington SCAD registry. Dr. Sarah Fairley, she got me involved in writing the SCAD PCI strategies paper. Big shout out to Esther Kim, Heather Gornick, and Melissa Wood. They're all 3 of them are involved in the International SCAD registry and have been great mentors throughout this process. Brian Gashardra and Sumit Gupta are our friends in radiology at MGH who are involved in our CCTA SCAD study. Sam Caldwell and Arthur Gines. Sam is our UW agreements manager, and Arthur is our radiology IT support specialist. They're both critical to the CCTA study. Thank you so much, and I'll take any questions.
Shauna, excellent presentation. Thank you so much for sharing all of that. And obviously, you've learned a lot here at the University of Washington, a lot about SCAD. So I hope that was informative. Let's go ahead and take some questions initially from the audience, if there are any. April.
Shauna, it was a fantastic talk and really great slides. Whole presentation was amazing. I have a quick question. You talk about one-time screening for FMD and, as the taking care of the patients who get transplanted with this and the process of it. Is that based on data, or does FMD just never develop 5 or 10 years after the initial SCAD event? Should these people be screened more regularly?
Yeah, that's a great question. We have like FMD expert consensus guidelines, but I'm not sure if that is completely based on data because FMD lesions can progress and you can develop new FMD lesions. I think just the current consensus is just to do the one-time screening to evaluate for potential lesions, but I'm not 100% sure if that's data-based or evidence-based, excuse me.
Rob.
Hi, I'd just like to echo what a fabulous talk that was, and I'm so glad to see how this has progressed. I want you to sort of comment on somebody else's work, that European trial.
Yeah.
The recurrence rate of SCAD remind me what the percent is?
Yeah, so it's 15 to 20% of patients have recurrent SCAD.
And so if they're enrolling 600 patients and they have 4 different groups, how big a treatment effect are they going to need to see any sort of difference? It seems like we're almost, certainly to sort of have a underpowered study, don't you think?
Yeah, I do worry about that. Unfortunately, SCAD is like rare, and so enrollment is very challenging. The majority of recurrent SCAD events occur within 3 months of that initial SCAD event. So potentially we'll be able to understand a treatment effect, but yes, certainly it's going to be challenging there.
That was a fantastic talk, Shauna. So I had a question about the probability of recognizing a patient with SCAD, because you highlighted that angiography is not without risk. So do we have enough data to do some data mining and have some algorithms? You mentioned young person, woman. Is that enough, or should be looking at other, if there's a large enough data set? Because if you find that CT is as good at angiography, then the question is going to be, are the cardiologists going to be nervous to wait, to do upfront CT? Can you comment about that?
Yeah, unfortunately, I don't think right now that we can diagnose SCAD without that coronary angiography. We do have a lot of supporting evidence from non-invasive studies, but you have to consider the differential diagnosis. I mean, there is a potential association, like I mentioned, with connective tissue diseases. There is some association with inflammatory diseases such as lupus, rheumatoid arthritis, and those patients can have like a thrombotic or embolic coronary event, and that's still within our differential diagnosis. Vasospasm is also common and more prevalent in women, and so teasing those out without having an invasive angiogram, I think, is just too difficult to do. All of those require different treatment strategies. As we know, vasospasm is predominantly medically managed. And so I wish we had an easier answer, as you mentioned.
David.
Outstanding talk. The benefit of cardiac rehab is very well established in elderly people and older people who have had type 1 MIs. I wonder, is there any evidence that it is beneficial for young women who have just had a baby and putting one more thing on their very busy lives to do?
Yeah, that's an excellent question. So there's only the Canadian SCAD registry has looked at this, and the main benefit for cardiac rehab is that it's associated with reduced risk of recurrent chest pain. Recurrent chest pain is very common. That's also about a fifth of patients. They have recurrent chest pain episodes. Not that they just have recurrent SCAD, but just that recurrent chest pain is common. We think that this is actually related to microvascular dysfunction. And so cardiac rehab has been beneficial for that. Also, just anecdotally, having consented the 37 SCAD patients, they're scared. They're scared to undergo, they're scared to exercise again. They're scared to get back to normal life. And I think cardiac rehab is beneficial for just building that confidence and letting them know that they can exercise again.
Other questions? Kenta.
Great talk, and I'm glad next year as we confront this, we'll have an expert in the room. One thing I struggle with is you share some really struggling statistics to that third of women status that are epidemiology or STEMI.
Yeah.
And the fact that I think the concentration of this knowledge is concentrated in the centers that aren't seeing steps and don't very much discuss in SCAD in general. So I struggle with how to sort of the strategies to distribute this knowledge. And also the fact that when they do present set, it requires an extremely high level skill. Can you maybe comment on some of the efforts about sort of education? Because I think really the onus is going to be on those presenting centers, which aren't going to be centers.
Yeah, that's an excellent question. So the iSCAD registry is affiliated with SCAD Alliance. This is a nonprofit organization, and actually there's a lot on SCAD Alliance, both for educating physicians, but also for educating patients. For any of my SCAD patients who well, for any patient who has SCAD, I refer them to that website. There's a SCAD Warrior app. It's available on a cell phone, but also just on their website that talks about what they should expect after SCAD. It gives them data. And I think that that's really beneficial. Having the international SCAD and having multiple sites work together is helpful for distributing that information. Kelly and I just had like a webinar discussing our CCTA study, and we've had webinars through the International SCAD Registry where we invite other facilities. And so I think, as you mentioned, the onus is kind of going to have to be on us to help our other institutions identify SCAD and then refer them when needed to our Center for Specialized Care.
Yeah, so there's been discussion between us to try to figure out, we would like more SCAD patients to come here just because of, I think, the additional resources we can apply to that. But what is that going to look like? And how are people going to get involved? I think that's something that's evolving because it also needs to wrap into FMD and connective tissue disease. So there needs to be a larger conversation with a larger number of people to do it right. I have a couple of online questions if you're ready for them here.
Sure.
Could you elaborate more on the hormonal aspects of SCAD? And do we know how postpartum or postmenopausal hormones play into SCAD recurrence?
Yeah, thank you for that question. Most of the studies on like hormonal relation to SCAD have all been like observational, very small case reports or case series. There's one larger study. I think it came out just last year. It had, I believe, 327 patients who had SCAD, and it looked at those who were on hormone replacement therapy versus those who are not on hormone replacement therapy, and hormone replacement therapy, including like oral contraceptives for birth control. And what they found was that in this observational study, that patients who are on hormonal therapies were more likely to have worsening 30-day outcomes. So more likely to have recurrent SCAD, more likely to have high-risk features on their SCAD presentation. But of course, that's observational data, and that's really the only things that we know about hormone replacement therapy. So the general consensus, which I think it's more of a precautionary measure, is just to discontinue all of those, especially estrogen hormone replacement. But if we look at the data, 55% of patients are actually postmenopausal who have SCAD. And so it's hard to tell that if it is like the estrogen supplementation or if there's some other factors related to hormones.
Can I comment on this?
Please.
So what we know from the connective tissue disease world is that estrogen actually protects the aorta. We know that we have less dissections in women with Marfan and Ehlers-Danlos and Louis Dietz. And so going back to your nice slide about inside out and outside in theories, I think those are two different diseases that happen at two different times in a woman's life. I think that during pregnancy, one thing happens, and after delivery, the other thing may happen. And I think that we have some data to suggest that. And so high estrogen levels are actually protective on vessel wall.
Great. So we're getting a little short on time, but next question. For men with SCAD, are there specific patient characteristics or risk factors?
That's a great question. Men with SCAD are more likely to have physical stressors as their like precipitating factor. We actually have one patient who has had multiple SCAD events related to weightlifting. But other than that, no, there's not any specific sex differences.
Excellent. And then this is from Young. Excellent talk. It may be that perhaps a significant portion of patients of young women who die suddenly may have died of SCAD, but without autopsy, and perhaps it's underreported. Any insights into postmortem analysis?
So most of our post-mortem analysis is going to be like our early studies. That's when we were just gaining an understanding of SCAD that wasn't related to bad fish and chips. But that's just from the 70s and 80s. And that's where we identified that just SCAD was not associated with atherosclerosis and predominantly occurred in women. Otherwise, I don't know that I have additional insights from post-mortem analysis.
Likely underreported. I think
Yes.
that's okay. Perfect. So we are at time. So again, Shauna, thank you so much. Thank you for your time or tenure, prisonership. I don't know. As the chief fellow, we appreciate everything that you've done. And again, thanks again to the Laughlin family for being such wonderful supporters. And congratulations to Shauna as the Bruce Laughlin Fellowship awardee this year. Thank you so much. Thank you. If there are any other questions, please feel free to come and approach us. Otherwise, thank you for a wonderful talk.